Thank you, Mansoor. Thank you, Jonathan, for the invitation. It's a pleasure to be here. It's great to see such a full room this early in the morning. Just a few words on conflict of interest. These are my conflicts of interest, and actually, as it turns out, none of them pertain to this presentation. So I will speak to you on acute heart failure, with an emphasis on the advanced heart failure patient. We'll look at diagnosis, therapeutic approach, when to refer, and can we prevent acute heart failure. Just a basic definition. Acute heart failure is a serious condition. It requires urgent medical attention. And it can present as a variable onset of signs and symptoms which are secondary to cardiac dysfunction. It's associated with reduced cardiac output, decreased tissue perfusion, and increased pulmonary and or peripheral congestion. And this occurs with or without known cardiac disease. So some patients presenting with acute heart failure may never have been diagnosed with heart failure or with any cardiac disease at all. It is responsible for a large number of hospitalizations in Canada. It is one of the leading causes of hospitalizations and is the leading cause of hospitalizations in Canada for patients over 65. This is data from CHI, the burden of heart failure in Canada. Keep in mind that most acute heart failure patients do require hospitalizations. And in Canada, we have over 45,000 heart failure hospitalization with an average cost of $10,000 plus per hospitalization and over $400 million on our healthcare budget annually. So it is a very serious problem. Now, as you heard in the previous lecture, more heart failure hospitalizations lead to worse prognosis. So we know that the survival of heart failure patients in general is 50% at 5 years. But as you get more and more hospitalized with heart failure, your survival drops off. So someone who's had the first hospitalization and a second hospitalization, you can see that their survival will decrease considerably with each hospitalization. And the reason for that is not quite clear, except that we know that acute heart failure represents neurohormonal, cytokine, inflammatory, and oxidative stress storm with hemodynamic compromise, which leads to end organ damage and dysfunction. And the more damage and dysfunction there is, the worse the survival is. Now, approach for early recognition starts with the basics. History, looking at the symptoms, and particularly looking at precipitating cause. Some precipitating cause can be actually dealt with immediately, such as an acute infarct, and one has to address that right away. So history and exam immediately on arrival. Labs should be done very quickly, again looking for positive precipitating causes, renal failure, high troponin. ECGs can show arrhythmias, can show an infarct, can show signs of myopericarditis. A chest x-ray should be done very quickly. Keep in mind that a chest x-ray that looks normal or relatively normal does not exclude heart failure. And finally, an echo should be done ideally within 72 hours to look at what kind of heart failure the patient has. Is there systolic, diastolic dysfunction, looking at pulmonary pressures, any valvular disease, any possible mechanical complications. Or an echo should be done urgently in the setting of somebody who actually is rapidly decompensating with acute heart failure. Now, there are cases when heart failure diagnosis is hard to make, and so there are certain scoring systems that can be used. This is one from the PRIDE study, which gives certain points for certain criteria, such as older age, orthopnea, lack of cough. Other use of loop diuretics, rails in lungs, and you can see here elevated NT-proBNP gives a very high score. So a BNP that is elevated in itself is not very specific. Unless it's very, very high, the specificity increases. In this case, they use an NT-proBNP cutoff, as you can see here, of more than 450 in patients under 50 years of age and more than 900 in patients over 50 years of age, and gives you a score of 4 points, which increases your probability of actually having heart failure. BNP, very useful in the emergency room, high negative predictive value, so if your BNP or NT-proBNP are low, unlikely, very unlikely that you have heart failure. Finally, just with respect to biomarkers, there are many that are being evaluated. You'll hear things like ST2, galectin-3, copeptin. These are all markers that are being evaluated to help with the diagnosis of acute heart failure, and perhaps might be useful in the future to help with an earlier diagnosis of when a patient is starting to head towards the decongestion, towards congestion and worsening heart failure. These are in evaluation and are not used in clinical practice right now. This dates back 15 years ago from Lynn Warner Stevenson, but I think it's still very much the cornerstone of how we approach patients with heart failure. This is what's called a 2-minute assessment of hemodynamic profile. On the left, you look at increasing perfusion. At the top, you look at congestion. Signs of congestion being orthopnea, high JVP, positive HJR, and S3, allowed P2, edema, ascites, rales. And signs of decreased perfusion being a narrow pulse pressure, cool extremities, sleepy, obtunded, ACE-related hypotension, low sodium, worsening renal function. And you can put the patients here in this 2x2 diagram, where most patients will present, fortunately, as patients B, wet and warm, but some patients, the very sick ones, will present as wet and cold. And there's a basic kind of approach to therapy, which is based on these. If you have profile A, you will adjust long-term therapy. Profile B, dry out, use diuretics and vasodilators. Profile C, warm up in order to dry out. And profile D, tank up the patients and give them fluid if they're dry and cold. This is a very cursory way of looking at it, and we're going to look at some of the data that supports the use of this, but you will find, unlike when we talk about chronic heart failure, we have a lot of data, a lot of evidence-based therapies. The data on acute heart failure is not so great, and we have a lot of negative studies. So a lot of what we do is based on experience and based on consensus that you'll find in guidelines, but not really evidence-based the same way as data that we have for chronic heart failure. So looking at our goals of therapy, obviously immediate stabilization of the patient with relief of symptoms comes first. When the patient is admitted or presents the emergency room, you have to prevent worsening of heart failure because some patients can worsen rapidly. And very important to remember, and there's good data to show, that if you don't improve the patient's well-being in the hospital and you discharge them and they're not considerably better, that their prognosis is worse and their risk of returning to hospital very quickly in heart failure is worse. Important to educate. Recommendations are to start PO meds pre-discharge, so start low-dose PO meds that you're going to use chronically. An echo should be done pre-discharge. An arrangement should be made with a liaison to follow these patients within 2 weeks pre-discharge so they don't fall between the cracks. And this has been evaluated. And one of the problems that we run into is patients come in with acute heart failure to the emergency room. They're treated, they're discharged before a plan is made and before any of this is taken care of. And of course, they come back 2 weeks later. And actually, the readmission rate in 30 days is something like 22% in patients who are admitted with acute heart failure. First thing to keep in mind, and you know what we've learned about looking at things like ABCs, your airway, breathing, and circulation, is we do tend to use oxygen, but there are some potential nefarious effects of oxygen, which increase the production of reactive O2 species, related oxidative stress with associated increase in systemic vascular resistance and reduction in cardiac output. So if your patient has a good oxygen, a good O2 sat, they don't need to be given oxygen, and actually giving them high levels of oxygen could be detrimental. So it's recommended to keep the O2 sat over 90%. Also, I think there was a point which we were using a lot of CPAP and BiPAP, but it's also not recommended to use those routinely. Only in patients with persistent hypoxia or an elevated respiratory rate more than 25 breaths per minute. And there is a trial, this is a large UK trial, that randomized patients to standard oxygen, CPAP, and non-invasive positive pressure ventilation, and they really found no difference in the three arms on mortality, intubation, or admission to ICU or length of hospital stay. So that we don't need to put everyone on CPAP, BiPAP, even though sometimes it feels like that it's a thing to do. You really have to evaluate your patient properly. And obviously, airway can always be protected with intubation in patients who remain with a high resp rate and a low oxygen saturation. This is a very simplified approach to look at heart failure. Once you've taken care of the ABCs, you have on the right your well-perfused patient, and on the left your hypoperfused patients. Now, fortunately, most patients presenting with acute heart failure will fall in the well-perfused, on the well-perfused side. But a patient that you're following in clinic with chronic heart failure, just because they actually have class 2 symptoms doesn't mean they're going to show up with well-perfused. They may show up with hypoperfused if they have another event going on, such as an acute infarct or an arrhythmia. Now, the advanced heart failure patient might be might be more likely to present on the it might be more likely when they present well perfused, if they're already hypotensive, if they already have renal failure and low sodium and have already been hospitalized, they may go quickly right back up around down that curve that shows worsening creatinine and LFTs and requiring inotropes. So what do we know about treatment? We're going to start with the side well perfused. Well, with respect to diuretics, we do have one good trial called the DOSE trial that looked at whether we should be using high dose, which is 2.5, the usual PO dose, or low dose, which is the same as the usual PO dose, furosemide, for patients when they're admitted with acute heart failure, or continuous versus bolus infusions, so either continuous or Q12 hours, to look at the primary endpoint of symptom and renal function at 72 hours. And really, there was no difference whether we're using high dose or low dose or continuous or bolus. There was greater early symptom improvement with high versus low dose, with only a slight elevation in creatinine for a brief period of time, and overall no difference in renal function. So really, either approach is acceptable with a target of 0.5 to 1 kilogram of weight loss per 24 hours. If there's resistance, you can add a diuretic, a thiazide diuretic, and once you switch to oral therapy, patients should be monitored for 24 hours. In terms of vasodilators in patients who have reasonable blood pressures with a blood pressure over 100 systolic, we do tend to use nitrates. Very little data to support that use. The data on nitrates really does not show reduction in mortality or hospitalization, but does show relief of dyspnea. There have been trials, RELAX-AHF, ASCEND-HF, ROSE trial. None of these trials that have used either Naseretide or relaxin or dopamine have shown a significant advantage over nitro. So at the present time, you can use them, but really you should probably just stick to nitro for cost-effective reasons. Ultrafiltration, fallen out of favor. There was a large trial, the CARESS heart failure trial, which looked at using ultrafiltration versus diuretic therapy. On the bottom here, you see the dosing of diuretic. They used a bolus and then a continuous infusion. And you can see on the right that the weight loss, which is the y-axis there, was similar in both arms, but the creatinine went more, in red, was more elevated in the ultrafiltration arm. So really no advantage to using ultrafiltration over diuretic therapy, unless really you have a patient that's extremely resistant and is no longer responding to diuretic therapy despite, for instance, inotropic therapy. Now moving on the left, the patient is more hypoperfused. We're looking more now towards inotropic therapy, possibility of cardiac support. In an advanced heart failure patient, you have to ask yourself, is this too much? Should I be escalating therapy? The decision really needs to be made. An advanced heart failure patient that has a poor prognosis, perhaps you need to be considering palliative care. In other patients, if you're really considering aggressive therapy, this is the time when you may want to consider referral to a center that has mechanical circulatory support. These patients, they start to fall into the cardiogenic shock kind of criteria, which are patients who have a low cardiac index, despite a normal or increased preload, and signs of tissue hypoperfusion, altered mentation, cold extremities, decreased cardiac output, high lactate. Very few patients present this way, but you have to be aware of them. In these patients, inotropic therapy is a therapy of choice. You start usually with dobutamine and milrinone if the blood pressure is adequate. But vasopressor inotropes such as dopamine and norepinephrine can be used if the blood pressure is low to support these patients. What does the data tell us on this? Well, actually, none of these drugs really help the patients. We use them, but they actually have been shown to increase mortality and certainly have not been shown to have any benefit in terms of, certainly no benefit in terms of survival and even in terms of decreased hospital stay. So we use inotropes because we really don't have many other alternatives. There are cardiac support devices for cardiogenic shock, and you will hear about these. You need to know that they do exist. We do use them. The IABP, the Impella, the Tandem Heart, the ECMO. These devices are available in certain referral centers, so you have to know they exist. Some of these will increase the cardiac output considerably, such as the Tandem Heart, the Impella, and they will decrease your LV preload, decrease your afterload. We do use them, but I must say that there is really very little data to support their use. It's mostly anecdotal, it's registries, but no data that shows us that compared to standard of care, they improve survival. There are algorithms for cardiogenic shock and using these devices, and you have to look at whether the patient has biventricular or left-sided heart failure. Probably the most important thing, if you're thinking of going down that route, is urgent referral to a center that can take care of these patients. So you start the patients on inotropes, and you start making phone calls to refer a patient to a center that can accommodate these patients. Why? Well, the sooner you get out there, the better, because we know now, when patients go into cardiogenic shock, when they have a myocardial infarction and they have a decreased cardiac output and decreased stroke volume, there's the mechanical part that happens, but there's a whole inflammatory pathway that happens, what you can see here in red. And when this inflammatory pathway sets in, there is actually very little chance of recovery. You can support the heart, you can increase the cardiac output, but patients will be very vasodilated and you will not see a clinical benefit. Couple of words because I'm running out of time. If BP tolerates, you should continue beta blockers. There are small studies and some systematic reviews that show that beta blockers should be continued in a hospital, even in patients that are very sick with acute heart failure, not in shock, but even patients who are on low-dose inotropes can continue beta blockers, ACE, ARBs, MRA, unless you have renal failure or hypokalemia. Can you prevent heart failure? You can. But you have to really educate the patient and optimize medical therapy. This is a trajectory of a heart failure patient. Patient presents 1 with decreased functional capacity. They get to number 2 where they get onto a nice plateau. That's where you have to push the medical therapy to prevent those dips that happen, number 3 and number 4. I can't emphasize that enough. That's how you're going to prevent heart failure hospitalizations. We know multidisciplinary care clinics work. So seeing these patients in these heart failure clinics can be of benefit. Self-monitoring, not so much, even though we ask our patients to self-monitor. A weight gain of 2 kilograms over 24 to 72 hours has a low sensitivity of detecting clinical deterioration. Especially in patients with advanced heart failure, there's social isolation and depression. And finally, there is one trial, the HEART trial, which randomized patients to self-monitoring counseling versus usual care and saw no difference on decreasing death or heart failure hospitalization. Telemonitoring, lots of studies. Unfortunately, none of them have shown improved survival or decreased hospitalization, probably because the filling pressures here you can see at the bottom left start to fill maybe 20 or 30 days before the patient's weight changes on the right in the rust color and the symptoms occur. So by the time you have the weight change and the symptoms, you're too late. The horses have left the barn. Implantable devices, there is data that's emerging, certainly with pacemakers and ICD, looking at lead impedance. There are monitors such as the heart pod, which can be put through transeptal puncture, and that can help guide therapy based on filling pressures. And there is the CardioMEMS, which is a PA sensor. There is one large trial, the CHAMPION trial in class 3 patients, which showed a 30% reduction in heart failure patients, in heart failure hospitalizations. This is what the device looks like. It's a PA catheter, and this is the data that shows that compared to the control group of standard care, this device decreased heart failure hospitalization in patients with either preserved EF or reduced EF. So there is some data emerging on this. There are also newer devices. This is an external wearable device. There is a study here looking at this device, which measures electrical current across the thorax, gets the data to the physician, and actually the physician can act on the results. And you can see here the first column, this is pre-recording, the green is during recording, the number of heart failure hospitalization, and post-recording. So there are devices that are emerging. You're going to see data and experience growing in this area. The limitations are going to be the cost of the devices, educating the personnel and the patients. And so far, they've only been tested in a select cohort of patients followed in experienced centers. The question is, will this data be generalizable? And this is the idea. The patient sends the information through a website, which goes to the physician, and medication changes are made. So I think there's a great future with this, and we'll have to see where that goes. There are lots of data to show prognosis in heart failure. These are some of the studies that are available looking at prognosis. And what you're going to find comes up recurrently is blood pressure at presentation, biomarkers, renal function, sodium level, O2 sat. If these are abnormal, the more abnormal they are, the worse the prognosis is. And I do encourage you to look at some of these scores, particularly Lee and Al there at the top, which looks at 7-day mortality of patients with acute heart failure. So in summary, acute heart failure presents usually with acute dyspnea and elevated left-sided filling pressure. You have to focus on assessment for congestion, perfusion, and a precipitating factor. Look for precipitating causes, Diuretics, vasodilators, and inotropes are mainstay of therapy. You can consider mechanical therapies in select patients if you want to go down that route. Newer monitoring therapies to prevent acute heart failure show some promise, and in advanced heart failure cases, supportive care approach may need to be considered. Thank you.